It's not their fault. Perspectives on pediatric obesity. I'm Janey Pratt, and I'm going to be speaking today about childhood onset obesity. I have nothing to disclose except that all the pictures were used with permission or were in public domain. I'm going to talk about children with obesity. It's not their fault. It's not their parents' fault either. I want to tell you a story about my 9-year-old son, Isaac. He has genetic thinness. He got it from his dad's side. I actually have 4 boys, and 3 of the 4 have it. My second son can eat 4,000 calories a day and remain in the 5th percentile for BMI. And my youngest, unlike a majority of children, has lost weight during this pandemic. So like any attentive parents, my husband and I took him to see the pediatrician. We talked about what he eats and how he likes frozen pizza bagels and Annie's macaroni and cheese. Then she told him that he should eat snacks at least twice a day, and she asked him what he likes for snacks. I love ice, he said. Like frozen water? Oh, yes. Okay, his pediatrician said, what else? I like cucumbers with lime juice and salt. Okay, but what about chips or crackers? Oh, yeah, I really love those rice cakes. At this point, the pediatrician just started laughing. She looked at me and said, I bet you wish your patients had the same taste. I treat obesity. More specifically, I treat childhood obesity. Like thinness, I have learned that obesity is genetic. Most of the children I treat have at least one parent with obesity, unless they're adopted, and about 1 in 5 have a parent who has had bariatric surgery. Twin studies show a 90% correlation in the height and weight of identical twins and only a 30% correlation in fraternal twins or siblings. Children born with certain genes are destined to obesity. It's not their fault. In 2013, obesity became recognized as a disease. Of course, genetic thinness is not a disease. There are monogenic disorders like sickle cell, cystic fibrosis, leptin deficiency, and Marfan's. And then there are polygenic diseases like heart disease, Alzheimer's, cancer, and of course, obesity. What makes obesity is a disease is that the storage of excess fat, and more specifically visceral fat, leads to significant morbidity, including fatty liver disease, insulin resistance, and inflammation. There are over 224 conditions associated with childhood obesity. Obesity is a disease. It's not their fault. 90% of people, when asked, believe that obesity is caused by eating too much and exercising too little. Many people believe that one's weight is under volitional control. In fact, most of the people watching this talk believe that obesity can be controlled by diet and exercise, even though numerous studies show otherwise. Don't worry, it's not your fault either. I assume most of you were born before 2013, when obesity was not recognized as a disease, when we understood much less about the etiology and the dangers of obesity. Children born at risk for obesity into a society where advertisements for sugary beverages and high-caloric processed foods are the norm. Fat blaming is commonplace. Doctors and nurses receive little or no education about obesity and are taught that diet and exercise are the standard of care for treatment. In these circumstances, children predestined to obesity are doomed. I want you to stop and take a step back. Open your minds and imagine what it's like to raise a child with genetic obesity. 18% of children in the world today have obesity, so chances are that many of you are or already have raised or cared for children with obesity. As shown in this growth chart, weight gain may start as young as 1 to 2 years old, or it may start around 7 to 8 years old, second grade. Or it may start in puberty. Either way, what we typically see is something like this. You might try to limit portions and withhold snacks, or make them eat low-fat, low-carbohydrate meals, yet they are still hungry. Unlike my son who craves ice and cucumbers, they may crave ice cream, chips, and juice. You'll take them to a dietitian and they'll teach you about red light, yellow light, and green light foods. You may also learn about the plate method. You sign them up for sports and get them out exercising. Unfortunately, data shows that while these methods might work for children who are mildly overweight, these methods will not work alone for children destined to severe obesity. They will continue to gain weight. They may develop abnormal eating behaviors like eating in secret, hiding food, or purging. They'll get teased and bullied at school for their weight. And every time you eat out with them, people will look at you and judge you for feeding your child. It's not your fault. Obesity is a disease. Severe obesity cannot be treated with diet and exercise alone. Pediatric obesity has increased fourfold in the past 40 years, while caloric intake in children has decreased by 300 calories a day over that same time period. Children with a severe obesity may eat about 100 calories more a day than their normal weight siblings, but they eat more because they feel hungry. Diets do not address the underlying genetic predisposition to feel hunger or unsatiated even after eating a full meal. Children with severe obesity who undergo bariatric surgery describe feeling less hunger, feeling full faster, and no longer feeling that food is controlling their lives. Children with obesity have health-related quality of life scores equal to children with cancer. Children treated with bariatric surgery has significantly increased quality of life. Pediatricians continue to prescribe diet and exercise despite the overwhelming evidence that it does not work for severe obesity. Here's a conundrum. Why did they send children with obesity and sleep apnea for tonsillectomy, an operation that clearly causes weight gain in children? I find it interesting that tonsillectomy involves permanent removal of part of a child's body, an excuse often used to recommend against bariatric surgery. Furthermore, we don't expect that children undergoing removal of their tonsils have to assent to the operation. We don't ask them to see a psychologist or put them through months of visits to make sure they understand the risks and benefits of the operation. Why should bariatric surgery be any different? Think about it. Isn't it just bias? Furthermore, when the tonsillectomy doesn't completely cure the sleep apnea, no one blames the child. But when bariatric surgery doesn't work, we know who gets blamed. But the truth is, it's not their fault. I saw a child in my clinic who had been seeing his pediatrician monthly. His pediatrician's notes read, "Counseled to lose weight." During that time, the child's BMI went from 45 to 55. Bariatric surgery, even in children, only produces a weight loss of about 15 to 20 BMI points, or 25% of the total body weight. For this child, we're already too late to help him reach a normal weight. He will struggle with obesity his entire life, and it's tragic. And it's not his fault. It's simply bias. His pediatrician hasn't read the AAP position statement on childhood obesity that recommends referral to a tertiary center for any child with a BMI that is 120% of the 95th percentile or higher. There are still not enough tertiary centers, but the AAP statement released in October of 2019 also recommends increased funding and establishment of more centers. Children with severe obesity born into an obesogenic environment are doomed, unless we act now and we act fast. Children identified early can be educated about their obesity. They can be relieved of the guilt about their disease and started on treatments that may prevent weight gain. They can be treated with bariatric surgery before their BMIs are too high. We can add medications for obesity that address specific deficiencies in their bodies. With appropriate treatment, children can have improved quality of life and increased life expectancy. But we need to recognize and accept that it's not their fault. It's not their parents' fault, and obesity is a disease. We need to stop judging people with obesity and start talking to them about treatments that work. They judge themselves as much as anyone, and all they need is permission to seek treatment. And most importantly, we need to let them know that it's not their fault. Thank you.
So, Janey, that was terrific. And it just makes me ponder so many issues about how we're going to deal with the uh, pandemic of obesity. And you bring up a lot of great points and a lot of challenges for parents. I too have four boys, and three of them are one way, and one of them is different. Um, and you know, everybody who thinks about this thinks of so many questions because you're dealing with kids and you're talking about rearranging their architecture, at a time where true consent is uncommon unless you're dealing with an 18 or 19-year-old. So the first thing that I saw that really got my attention was when you made the comment, and you said it in passing, and I don't want anybody in the audience to miss this, that the obese kids eat on average only 100 calories a day more than the non-obese kids. So why can't we as parents exercise our way through this?
So the problem is that there's something wrong with how the obese kids' bodies are storing fat. We have kids that come to us who are eating all kinds of crazy stuff, or binging or purging and things like that. But most of the kids we see actually have fairly healthy diets. And the fact is that their bodies just metabolize it differently. And for some reason, and I think eventually we may understand this. For some reason, they don't they don't get rid of the fat. They keep it, and their bodies are extremely efficient at every calorie that goes in their body gets absorbed and gets used. Many of us just don't absorb everything.
So wait a minute, this is the supersized generation and all those movies. Why are we seeing this now to a greater degree than what we thought about in the 70s and 80s?
So there's a couple of things. One is that the genetics actually starts in utero in the grandmother. So there are changes to the eggs inside the woman's body when she's a fetus inside her mother that affect uh, the grandchild has a higher risk of obesity. So there's something going on inside in utero at a very far back, not just your mother but your grandmother. So there's that, and then the second thing is that there has to be some kind of toxin that is setting off these genes, and I do not know what it is. There's something that's affecting the epigenetics of this genetic basis that we already have. Like a lot of us probably carry these genes, but they don't get turned on. And there's got to be something in our environment that's setting it off. And I honestly don't know what it is. I mean, maybe it's corn syrup. Maybe it's high fat diet. Maybe it's just ultra processed foods. Maybe it's something in the ultra processed foods. Maybe it's GMO. I don't know. I have no idea. But I do know that there's something that is accelerating the obesity epidemic. But a lot of it is just coming from the fact that the in utero environment, if you have obesity when you have your children, your risk of having a child with obesity is 50% more than if you've had bariatric surgery and then you have a child. And I don't
Wow.
think that's environment. I think I mean they've normalized that. They've done sibling studies born before mom had bariatric surgery, after mom had bariatric surgery, and those studies clearly show that you're decreasing your child's risk of obesity by not having obesity when you're pregnant.
So these kids are particularly food sensitive because the operation reduces their calorie intake, which becomes much more important in kids for whom this genetics and epigenetics is turned on. I mean, because how does the operation work otherwise?
Well, so the operation actually, I don't think it has anything to do with calories, honestly. I think the operation, what we know about the sleeve gastrectomy and the gastric bypass, is that this whole notion that they're related to decreased intake and increased malabsorption is really not the case. It really is that you're affecting the neurohormonal pathways that control satiety and hunger and control metabolism of the along the glucose and insulin axis. So the increase in GLP-1 we see after both sleeve and bypass, the decrease in ghrelin that is profound after a sleeve and somewhat after a bypass, the increase in PYY, and then there's dozens of other hormones that are involved in satiety and hunger and that control our how much we eat and how hungry we are. And when you talk to kids who've had a gastric sleeve or a gastric bypass, they'll express to you that they're not feeling that hunger they used to feel, or that they're feeling, more in control of their eating. So it's really changing something inside their body. And when I operated on adults, they used to always say, "Are you sure you didn't put something in my brain?" And so I think it's sort of, I mean, there's clearly some neurohormonal pathway that we're affecting with these operations that is helping them lose weight. And
So we
it doesn't work for everybody. So that's the
hmm.
interesting thing, Steve. There's still about 20% of kids and adults who either don't lose weight after a sleeve or who regain the weight within the first 2 years.
Hmm.
And I think, I don't think that's a failure of the kid. I think that's a failure of the operation to hit whatever neurohormonal pathway it is that was causing their obesity in the first place.
Wow. I mean, and you have to. It's always about the right patients and the signal, and we don't know what the signals are. We talk about in adults that only 1% of the population who is candidate for bariatric surgery gets it. Are those numbers even more discouraging in kids?
They're horrible in kids, actually. Even as this pandemic has increased in kids, we're only doing about 1,400 cases a year. This was the last count we had was about 3 years ago in children. 1,400. And there's millions of kids with severe obesity who would qualify for the surgery. So there's definitely a lack of access, and there's a lack of acceptance still. Even though the AAP came out with this great statement, people haven't bought into it yet. They haven't read it. Um, they haven't heard the message, which is that this is the best treatment we have for obesity.
Have you met parents that are sort of fearful of making decisions to rearrange the plumbing in their kids? I mean, how do you get parents through these things?
So a lot of parents are. I think that most parents are actually very nervous about having their kid have surgery for any purpose.
Sure.
I certainly was. I mean, my kids have had surgery, and I never went into it easily. Um, but I start out with a teaching session where I basically show them the data. And I say, this is the data we have. This is what the AAP recommends. This is why we're doing surgery for this disease. And just like I said, in terms of doing a tonsillectomy for sleep apnea, it should be as simple as that. It should be as simple as saying, oh, your child has sleep apnea. We're going to do a tonsillectomy, and that's going to fix the problem, 80% of the time or 75% of the time. It's the same thing with this. Your child has obesity. We're going to do an operation, sleeve or bypass, whichever, and it's going to fix your child's obesity 75 to 80% of the time.
What do you do when the parents don't agree? When one parent says, I think this might be the answer, and the other parent says, we're just going to run them on the track more.
Yeah, I talk to them. I show them the data. It doesn't always work. I have had kids that and that don't get surgery because of that. And I actually had there's a great NPR podcast about a patient of mine who we had to wait till she was 18 because her parents didn't agree that she should have surgery. And we waited till 18, and then we did her operation, and she did great. And she's done great as a young woman, and actually runs a support group now for kids who are interested in this. So I think that so sometimes you just have to wait. But usually I'll just talk to the parents, and see if I can bring them around and see if they can help them understand. And then the other thing I do is I just keep them in my program. So, even if they're not interested, I say, well, come in the program, meet with other kids, and we have a group program, so the kids are all together, not on, they're together on Zoom like we are now, but they're together. And I think when they stay in the program, sometimes the parents come around.
Do
It's harder.
they go ahead?
It's harder when the kids aren't interested, you know, um, because a kid doesn't want to have surgery, or the kid is afraid of surgery, or they're afraid of needles or whatever. That's a little more difficult, actually, because I'm not going to operate on a kid who doesn't want surgery. But, on the other hand, it's the best treatment we have for obesity. And some kids don't necessarily see their obesity as a problem. So that's more difficult, actually.
For sure. And we don't want to get, too deep into the whole body shaming and those types of issues. Do you see more um, boys than girls, or the other way around?
So in the adult population, it's definitely more female than male. In the kids, it's much closer to 60-40. So about 40% of our kids are male and 60% are female. So it's a much more even um, distribution in the kids that we're seeing. But we also, I think the other thing is that ADHD and obesity are linked. And so we have a lot of boys with ADHD who come through our program. And then we also have a lot of kids with developmental delay. And it's been our experience that the kids with developmental delay do really well, especially autism, because autism kids tend to follow rules. And so if you give them simple rules to follow, they're great at basically at doing what you ask them to do. And then they just do really well after surgery. I think it's been a pleasure to take care of many of these kids.
Do many of these kids present with diabetes?
Yes, about 30% of our population has type 2 diabetes. And there's actually a very interesting recent study which sort of lights a fire under me about getting the kids with diabetes through to surgery as quickly as possible.
Sure.
And that's the study that shows that the complications of diabetes type 2 in children are accelerated compared to in adults. So they get renal failure sooner. They get eye damage sooner. They get all of the microvessel disease sooner and more aggressively. And they turn their type 2 diabetes into type 1. They're basically killing off their beta cells really rapidly once they develop type 2 diabetes. So it's incredibly important to treat these kids. Um, yeah, and I showed that graph during the talk which showed the Today trial versus the Teen Labs. And the Today trial was an aggressive medical management of type 2 diabetes. And the Teen Lab study was a bariatric surgery. And basically, the kids with diabetes did significantly better on all fronts with bariatric surgery than they did with the medical treatment. So it's true in kids as well as in adults.
Yeah, and we now know that the longer you wait between the diagnosis of diabetes and treatment, you don't get the really robust treatment of the diabetes, so we have to attack these early. What about getting these operations paid for? Have you had a lot of struggles? Maybe the payers think this is experimental, the way we deal with devices. What's your experience been in with the payers?
So it was the same in Boston as it is in California where I am now. Once your program is established, it's not as much of a problem. So once you start doing a certain volume, the payers get used to, oh, that's the Stanford program. Okay, we'll pay for that. We still run against certain insurance companies. So we had one patient who had a specific exclusion in her insurance. So her parents switched their insurance, and then we did the surgery like 6 months later because they had to wait for that. But usually, I would say 50% of the time it goes straight through, no problem. 50% of the time we have to call and talk to the director or the medical director and get it through. And of the 50% that we have to talk to them, 95% of those we get cleared.
Sure.
So we really do, it does take a little bit more work, but it's really not a major barrier in my eyes at this point, at least in California. Now, it really depends on the state. We have CMS on board, but we did that by taking them to court twice. So once as you're establishing a program, it can be challenging. But once you get established in a location with those insurances, and it's Medi-Cal here in California, then it all works out.
And we're glad you won. And then lastly, for those parents that are a little leery of rerouting the plumbing, so to speak, what has your experience been with people asking for endoscopic sleeve gastroplasty that Bruce Shermer will be talking about next? Uh, Bands, what are the alternatives and how popular it is, and what do you tell the parents?
So when we talk about bans, it's easy to convince them that it's not the right operation. I haven't had anyone ask for an endoscopic gastroplasty yet. They do ask for balloons a lot. And once I explained to them that, I mean, we may do them in the future, but it's really not a long-term fix. So
Sure.
most of the kids we're seeing, their BMIs are 45, 55, 65, 75. They're not going to they don't need a balloon. They need a definitive surgery. So I think it's not been a problem for me. Um, I do have people ask about them often, and I will tell them the data that's out there, and the data that's out there in kids for a band is not that great. So it's pretty easy to convince them that the sleeve is probably the right operation for most of them.
So Janie, if you would share what you would consider in your experience with this, sort of the most dramatic impact of doing bariatric surgery in a child, and what it meant to his or her life, I think we would be really grateful to hear that.
So there are so many kids that I've operated on who come to mind when you ask me that. I just, it's hard to choose just one. But there was this one young man who came to us, and he was really depressed about his weight. Um, his hair was long, and he just really felt terrible about himself. He just held himself sort of down and covered, and wore very loose clothing, and he had a BMI around 50. And he was just a very sort of sad kid. He had diabetes. He was Hispanic, and we did surgery on him. He got through the program fine. He just sort of, plugged along every day. He had surgery. He came back 6 months later, and he had already lost like 45, 50 pounds. And he had already started to change. And it was really amazing to watch him because he had started to get a little bit more self confidence. He was a little less depressed, and he was carrying himself a little differently. And then I saw him at a year, and at a year, he had lost 100 pounds. And he was a totally different kid. Like I almost didn't recognize him.
Wow.
He was smiling, he was conversant, he had his rollers board with him. I mean, he was just unbelievable. And I've seen him back, I think 2 or 3 times since then, once a year. And it's just a pleasure to see him every time because he comes in, he's growing up into this young man. And he was about 14, I think, when we did his operation. And he's just so full of life and so happy and so um, just a different person. It was been remarkable to watch him grow up. And I love watching kids grow up anyhow. But I just for this kid, it just was such a turnaround for his life, and he's just such a happy, confident child now, and it was just a pleasure to watch.
That's amazing, and it really shows you the impact and why it's so um, scary that the numbers are so low and there's so many more people to help. Well, that's that's actually a really heartwarming story.
Thank you.
And I guess my final question is for those adult bariatric surgeons for whom somebody may bring a 14 or 15-year-old child into their office. And as you know, some hospitals let the adult surgeons operate down to 12 or 13, depending on their circumstance. What advice would you give to an adult bariatric surgeon when a child presents to their office?
So I would say if you can partner with a pediatrician who's interested in obesity, and particularly one who may be obesity medicine um, uh, accredited, um, and have a psychologist who's comfortable working with families and have the type of support network that that kid needs, absolutely just operate on them, because we need surgeons who are willing to operate on the kids, and we need surgeons who are willing to start a pediatric program. I wouldn't do it without that kind of support, because the kids do need support and the families need support. And it's good to have other kids. So I would say if you're going to do it right, and partner with a pediatrician, have meetings about the kids, and just start in a program where you bring kids in as well. I mean, it's there's plenty of children of your patients who need surgery, and having a program for them would be the best thing to do for them. I mean, we really need more pediatric programs, and I would encourage you, if there's one in your area already, just refer them there. Otherwise, if you can start one, please do, because again, we need more programs. The MBSA QIP approves programs. You can get adolescent privileges if you're already an accredited adult program. Um, but we really do need more people doing these surgeries for kids. Kids are not like adults, like surgically. The only thing I would say is beware the liver. The kids' livers are fragile, and the same with their small intestine. It's like they're a little different than operating on adults. So if you're going to do bypasses, it's a little more challenging.
Well, that's awesome, Janey. We wish you were here. Um, we hope to see you next year. We're all fighting this pandemic together, and we are so grateful. Um, that you're part of the army that's helping, with to fight this. 1,400 operations is nothing in a bucket and an ocean of obesity. So great work, and we look forward to seeing you at Sages next year. Thanks so much.
Thank you. And thanks for having me.